For question 13, if you said B, primary biliary cholangitis, you are correct. Both primary biliary cholangitis and primary sclerosing cholangitis can present in a similar way, but this is a female patient with a history of another autoimmune disorder, specifically thyroiditis, making PBC the more likely of the two. We're now going to move on to immunologic liver diseases. The presence of another underlying autoimmune condition and female sex increase the risk for autoimmune hepatitis. It can occur acutely or have a more chronic indolent presentation, and at presentation, patients will often report fatigue, right upper quadrant pain, and jaundice. AST and ALT will be elevated, hyperbilirubinemia and alkaline phosphatase elevations being much less common. Typically, IgG, ANA, anti-smooth muscle antibody, and anti-liver kidney microsomal antibodies are elevated. These can be used to determine the diagnosis, but biopsy can also be helpful to confirm autoimmune hepatitis. Treatment is indicated if patients are symptomatic or if the AST and ALT are at least 2 times the upper limit of normal. And steroids and azathioprine are mainstays of therapy. The only curative therapy is transplantation. Primary sclerosing cholangitis has a strong association with ulcerative colitis and is usually indolently progressive. Patients will often present with fatigue and severe pruritus from hyperbilirubinemia, followed by jaundice and weight loss as the disease progresses to cirrhosis. Alkaline phosphatase and bilirubin will be elevated, and diagnosis is typically confirmed by the appearance of biliary strictures that look like beads on a string on MRCP. Cholestyramine can help improve pruritus, and biliary stenting can be helpful to open up the dominant strictures, but the biliary tree will continue to develop new strictures which will cause biliary obstruction, ultimately leading to the development of cirrhosis, as well as potentially liver abscesses. So ultimately, liver transplantation is the only cure. Primary biliary cholangitis is more common in women and people with a history of other autoimmune disorders, particularly CREST, Sicca syndrome, and thyroiditis. Patients will present with symptoms similar to PSC, with fatigue, severe pruritus, and jaundice. They may also develop malabsorptive diarrhea from decreased ability to absorb fats due to decreased bile excretion. Alkaline phosphatase is typically 3 to 4 times the upper limit of normal, and antimuscular antibody will be increased. These labs can be enough for a diagnosis, especially as early in the course of the disease an MRCP may not find any biliary duct abnormalities. Later in the disease course, MRCP will see periportal inflammation and edema around the portal veins, as well as biliary stenosis and strictures or effacement of the bile ducts. Magnetic resonance elastography can assess for liver stiffness and may see a paucity of visible bile ducts. Ursodiol is a mainstay of treatment and can slow the progression of the disease, but ultimately transplant is curative. Let's go on to another question.